Welcome to Frontline Nursing, a Nurseminder production that gives you an insider's look into the daily life of nursing from those who are currently working on the front lines. Whether you're considering nursing as a profession, you are a student already, or you are a nurse looking to transition towards a new patient population, this show will give you some behind-the-scenes information to help you guide your career. Today on Frontline Nursing, we are joined by Dallas O'Donoghue, an LPN who has been working in the field since 2016. She has a wide variety of experiences, and we are excited to have her on the show today. Welcome, Dallas.
Hello.
Hey, so let's first of all just get started. I'd like to hear people's origin story and what brought you to nursing. How did you know nursing was going to be your career path?
Okay, so that's a little bit of a story. So anyway, I was doing my Bachelor of Science degree at one of the bigger universities here in Edmonton. I was doing psychology at the time. I thought I was going to be a physician. That was something I wanted to do based on a number of factors, home life and what have you. I want to be a physician. I think that'd be something I'm interested in. Well, through life, you discover different things. I joined the military in 2011 in the medical field as a medic. And found that I liked more patient contact. And I found out what nurses actually did, and it was a completely different thing than actually what you see on TV. So I went, hey, maybe I'll try and get into an RN program. So in around September of 2012, I applied to get into a nursing program. Well, that didn't work out so well. I got in initially, and of course, when you're doing fourth-year courses, you discover these are a little bit more difficult than we thought. Okay, our marks went down a little bit, so found myself finishing my psych degree, and okay, now what am I going to do? I'm at the end of this road. What's the next avenue? So again, looking for healthcare-related professions, including lab tech and what have you. And I went, okay, maybe I'll be an LPN. That can segue into RN later on. So that's where I started in January of 2015. And the rest is history. I've worked in a couple different places since that time. Actually, I started as a porter in a merge department in a large center here in Edmonton, which led me into my first job, which was emerge nursing again. I learned a lot there with the different skill sets. I learned how to do, from the military, I learned already how to do ECGs, how to do lab draws, which was really condensed, as they call in the military, education by fire hose. Like you retain a lot of information very quickly. So I had a lot of that background before I started nursing. But anyway, back to that story. So I went into emerge nursing. It was a little bit overwhelming at the time, so I started, this is too much for me after about 3 to 4 months. Did some soul searching and found out a lot about how to do, number one, how to write a proper resume. Actually, I went through a resume writing service, which can help a lot, to pinpoint keywords on your resume. And I applied to about 750 to 800 positions within one of the major health services here in Alberta, both of them actually. Wasn't finding anything, got probably an interview every 2 weeks or so, and then I found myself at another urban center here where I was floating between orthopedic surgery and internal medicine. Internal medicine was quite interesting because you got a variety of different cases. Yeah, so I found myself between orthopedic surgery, internal medicine, and then I found myself in my current job, which is floating between, 13 different medicine units. Sometimes I'm on a different unit every day. Sometimes I'm split between two in a given day, which you have to be quick on your feet. Number one, you have to be organized with what you're doing. One thing I find about the new computerized system that makes it really easy, instead of the old paper brain that we're all used to in an org plan, it's all quite laid out nicely with the computer. You have all your tasks there and you just check your brain, and you can check your orders as well. It makes it quite convenient. But again, with the job that I do, I have to, number one, if I don't know drugs, that's a big thing, researching our drugs. With the biggest resource you're going to find is the Parenteral Drug Manual. Also Lexicomp, which is what the pharmacy uses. And there was a trick and a big thing I learned with nursing is listening to your allied health professionals, especially your physiotherapists, your pharmacists, and what have you, because they gave me a little trick with drug compatibility. Within Lexicon, there's something called Trissel's IV compatibility. One of the best tools you're going to find when you're looking up compatibilities. So again, with with medicine, nursing, I never thought I'd find myself there in a million years. I thought medicine, okay, it's going to be just the older population from 55 on. I don't know what I'm going to find myself in. So, of course, I went medicine. Okay, let's do this. So I've done a bunch of different things. I tried OR nursing for a while. That didn't work out. And I found myself in medicine for the past 2 years, floating, and I've gotten a lot of different experiences. One of my favorite is hematology, because you get some pretty challenging cases there. You work within my job now, I'm working with a lot of pulmonary patients, a lot of which you get to specialize with chest tubes and find out what those are about. OptiFlow, what the settings are with that. And you get a lot of different diverse training within medicine float because, you need the skill set. I would suggest to somebody that wants to start out, floating in medicine or surgery and going from there, because you're going to diversify what you truly like, and go from there. And the best part about my job is I'm never in the same place for a day. So
for some people that's a great thing, and for others they want to have those same connections every day. Stop for a second and go back, because you just dropped a ton of information there, and there's so much to dissect. I'm curious to know, you had mentioned that you were working as a porter in ER, and when you had decided to go into nursing, was emerge nursing your initial career of choice because of that?
Potentially. I had some emerge background from being a medic in the Army, so I thought, okay, maybe this might be a skill set that I might want to specialize in. So again, I gained a little bit of perspective being a nurse. It was totally different than being a porter. You have an outside view. When you're a porter, you see things, of course. Plus, you have your background from the military to lean back on, and you're going, well, I gained a little bit of experience, but I wish I would have, now thinking back 3 years later, I wish I would have had the background for medicine to move forward to go on to emerge nursing, because being a new grad in emerge is touch and go, because you should have a background to lean back on before you go into a high acuity area like that.
Yeah, that's one of those conversations that kind of comes up every once in a while. And I have a belief that 2 years of working on a unit, just really focusing on becoming comfortable with the skills, is important for you then to be able to put the skills into automatic mode when you go into a higher acute area, so that you can start to work on those more complex pieces. I do know that there are nurses who go straight into emerge and they are successful. They have a great mentor. But it's been my experience that I feel like it's a stronger nurse when they have that background initially.
Exactly.
Yeah. So interesting that you had experienced that as well, because of that military background, because of the portering and having been around that environment. You still felt like that was missing in your preparation to be the best you could be.
Exactly, because they give you a finite number of buddy shifts, and then you're told, okay, go. They keep you in a less acute area of emerge, but even then, it's quite quick, fast-paced. And if you haven't wrapped your head around the skill set yet, it's kind of overwhelming at times. That's why I went, this is way too much for me.
Yeah, and you know what? That's great self-awareness. And as you said, now you may feel like you're a little bit more capable and desire to go back into emerge with all that broad experience you have. So very curious and fascinating to hear that you wanted to be a doctor at first. And that somehow your exposure to nursing, we sucked you in.
Yeah. Well, you never know, like I said, I did a BSc in psychology. I didn't have the marks necessary to get into med school, so I went, well, I want to go into healthcare. This might be a area I'd like to try, is nursing, because you are exposed to quite a bit. But I found doctors do a lot of administrative and delegating, whereas nurses are the doers, which is what I'm into doing.
You want
We
to be
like
frontline.
doing.
Yeah. Yeah.
Exactly.
Yeah. So that's fascinating. I'm happy you found your way into nursing because you've been now nursing for, is it 4 years?
Coming up, yes.
4 years, yeah. Now, how helpful has your psych degree been in nursing? I'm curious about that combination. So I'm thinking back, when we get a psych patient on a medical floor, they are often not, they don't get the best psych care. They get really great med care, but the psych kind of is a little bit off to the side,
Mhm.
only because we don't have that developed skill set.
Mhm. So again, I that was my major. I concentrated mainly on psychopharmacology, behavioral psychology, and what have you, and neuropsychology. So having that background really kind of helps seeing the practical side of it and seeing what the manifestations are within the population. When you see that, you can be more empathetic with their care and spending more time, because with the psychiatric and the mental health population, you do have to spend a lot more time taking care of those folks because they may present differently, um,
Yeah.
especially with how they experience pain and how they experience and articulate what they're telling you. You have to ask them in a very specific way. Same thing with, I find with dementia patients. Again, you have to spend the time and articulate your message in a very specific way to understand what they require and what they would like.
Mm-hmm.
Because you have somebody that's throwing all their clothes all over the place, and you're going, okay, how do I help them now? And
Right?
articulate what I want them to do so that they don't hurt themselves or hurt me, number one, and so that we don't find ourselves in a physical struggle. Again, just having that background really helps to try and figure out what exactly is going on mentally so I can help them the greatest I
Mm-hmm.
can and be the patient advocate for them.
Do you have a particular strategy that really works well for you in those situations? I'm thinking, like, I'm going to share a little story here. I remember working in a medicine floor.
Yeah.
No, it was burns and plastics. And one of my patients had a psych history. And I'll tell you what, I'm pretty black and white in some ways. In other ways, I have a lot of flexibility. But when it came to medication admin, there's the term clock watcher. I'm not a fan of it, but it certainly paints a picture of somebody who's, calling every 2 hours when the medication is due, and that tends to be a label. As I said, I'm not a fan of labels, so I went in there and we did all the conversations, all the education, this is what I really want to know. I want to make sure I'm giving you the right treatment at the right time. So you call me when you have some pain. And she was like, yeah, that's great. And we were probably 20 minutes talking. I turned around, I got outside the door, and she was yelling at me, "Get me my effing meds, you be." I was just like, I spent so much time with you. She was really mad.
Well, I can tell you of a scenario, probably it was about 3 years ago when I was in Emerge. Lady, again, what you would label as a clock watcher per se. Anyway, so we had the ability to give this lady had chronic pain. But again, there's different modes of administration for drugs, right?
Mm-hmm.
Being IV direct, in a mini bag, something that works for the patient, what's going to work best for them. So anyway, this lady, honest to God, she was ringing. She had it on her phone, programmed on her phone. Every hour, IV push, IV direct. Knowing IV direct acts so fast, I went, okay. I said, how quickly is this how quickly is this working for your pain? Well, that's why I keep ringing. So anyway, I said, let's try this amount in a mini bag and see where it goes. Anyway, hung the mini bag. She was quiet for 3 hours, didn't ring or bother anybody, and she apologized in the morning. So just knowing the patient and knowing what they're going to ask for instead of just going quickly to let's just do the quickest measure sometimes is best.
Yeah. So is that your strategy then, is to engage them, especially for
Yes,
those who have the chronic pain and are they know their pain. They know what's going to work for them.
yeah, exactly. And giving them a little bit of pain education, because there is some older people that will say to you, I'm scared of this med. I don't want to take it. So you give them, coming from the surgery background I did before in my second job, was making sure that they know what the pain curve is and understanding that, so that they have an understanding of their pain. I said, pain is subjective. Your pain is different than my pain is different than their pain. So tell me how you experience pain and how I can best give you what you need and when you need it.
That's fabulous.
Finding meaning in pain, that's a big thing with folks that are older and have chronic pain.
I think that's a big thing in everybody who has pain. You know, it's interesting. I've had some knee and shoulder issues lately, well, last year. And when they ask me the pain scale, I actually find it very frustrating. And it's so new to me because we use that as a nurse all the time to try and gauge what's going on. But I actually don't like it. And I'm finding that there are some gaps in what we do as a nurse on a regular basis to really understand what our patients are going through. It's been a kind of fascinating journey for me on the other side because I'm still dealing with it. But that's a story for another day. Maybe I'll have to do my own podcast about my aches and pains as a nurse. Oh my goodness. So you've actually gone through an awful lot in your short 4 years. I mean, you've been on this last floor for the last couple. But in and out of different places. So the orthopedic hip and knee surgery, we talked about the OR, the emerge. Where else was there another one? Did I miss one other than medicine? I think that was
just medicine. Those are the three big ones.
Yeah, and so learning a little bit about yourself in each one of those, what were some of the challenges you've come across through your journey of nursing? And either how did you overcome them, or what would you suggest for others if they're having the same problem?
I would suggest to folks, when they're picking their final practicum, because you won't know until the end, pick a broad either surgery or medicine, because that's your best goal. Don't subspecialize until you've done those for at least a year or two. Because I know there's an option here with one of the local colleges to go directly to the OR. You have to have some floor experience before you do that, just to engage with the patient and understand, number one, medications. Number two, assessment skills is a big one too, especially going into the OR. And a big difference I found with OR nursing, yes, you have to be a better patient advocate, period. And there's different communication styles in there. I mean, I've had what are professional surgeons, they get frustrated with you or they're having a bad day and they throw things on the high stand, and you got to remind them to be safe and communicate with them. And that's where the patient advocacy piece comes in, where you're saying, oh no, that's not sterile, we got to stop and do this again. And you try and, well, that comes with the circulating role. You're making sure that everything's safe, everything's sterile. When you're in the scrub role, of course, you're the biggest patient advocate you can be with that, making sure everything's sterile. But it's a bit totally different world when you're communicating with a physician, another nurse, and having the patient on the table. It's totally different. So when pardon me?
Then ward nursing, you mean?
Yes, very much different. You have to be a better patient advocate, and you have to, the biggest thing, there's a lot of strong personalities in the OR. Sometimes the preceptor, you have to get along with them. They're with you for 3 months with the LPN. Portion of it, it's 3 months, 420 hours. It's quite a difficult program, I will say that much. And you have to be really committed to it and make sure it's something you really want to do.
That is a challenge in knowing where you want to go for your preceptorship, because there's no real exposure at the time at which you're selecting that. And I think in that process, you've done your long-term care. I don't even know if you've had your med-surg clinical at the time that you're giving your preferences.
I think it's med-surg that you're going to decide yay or nay. But what I would say is pick medicine or surgery, because you're going to get ward exposure, which is going to tell you, okay, where do I want to go from here? Because you're on one ward for 8 weeks, I believe it is now, and that's going to tell you, really, do I want to do medicine? Medicine is a good segue into anything else, because I've heard from a lot of the folks that work in ICU and beyond, they said they accept nurses that work in medicine more than they do surgery, because surgery, you're working on a specific floor, you're getting specific types of surgery, and that's what you routinely care for. In medicine, you never know what you're getting.
Mhm.
For example, go ahead.
No, you go ahead.
For example, and it depends on the physician you're working under too. You'll get discharge 4 patients, make sure they have everything they need, and make sure they get the education they need with prescriptions, what have you, make sure all your charting's done, and then you discharge 4 people. This happened last Friday, for example. You've discharged 4 people, you got 3 people waiting out the door, and then you got to start rushing. One thing I found working, because some of the specialty units you only have 3 patients, working in internal medicine, you have to be very fast on your feet because you're spending between 5 and 10 minutes with each patient. You've done your assessment, done your vitals, then you're moving on to meds pretty quickly.
It's fast.
And one of the best things about the new system I found is reduced medication errors, because you're scanning every person and all the meds. So you still have to physically check what you're giving, because obviously medication errors, 10 writes of medication admin. But yeah, that's one of the pluses with the new system, that you ring the patient, you check their ID, so that's your double identifier, and you're ringing in each pill or drug that you're administering. So that's your...
So you have to scan all of that now?
Yes.
Oh, that's new. Since we didn't have that in the last facility I was in for my clinical group. They have not come into the Connect Care. Is that part of Connect Care?
Yeah.
Okay. Yeah. Oh, that's interesting. Fascinating changes. There's always growth, isn't there?
Yes. Like,
Yeah.
for example, when I went to the OR here in September for the second time,
Oh, so you went back.
I did, yeah. A lot of things happened in between that we won't talk about, but anyway.
Okay.
I went back to the OR for some more additional training. I had left when they still had paper charting. When I came back, they sent me for Connect Care training. I went, oh my goodness, what is this? I'm going, oh, how am I going to do this? Because they've got phones now that you can scan your meds on the phone as well. Called the Rover. And it's all good training. It's a very good system overall. It enhances patient safety, which you want to do. And there's less medication errors. There's a lot less transcription errors with drugs, because it's real time and you don't have a big clunky chart that you're flipping through and everybody's fighting with. So more organization that way.
Oh, that's awesome. Now, there's 2 things I want to circle back on. One is you were sharing how you think it's beneficial to go to medicine or surgery for your final preceptorship. And I will just add that when students ask me where they should go, I also suggest that. But my motivation is different. It's because that's what your NCLEX exam is based on, is medical, surgical, nursing. 90% of your questions will come from that, because that's where most people find their jobs. And so for me, I think for a student who's going out there, that is the best place to go, because it's going to set you up for your NCLEX a little bit better than a specialty unit would. And the second thing I wanted to come back to, you've mentioned this word several times, so it's really important to you, and that is advocacy.
Yes.
And I'm wondering if there's a story behind this, if there's an experience behind this that really has made this valuable.
There's many. There's so many. Let me think. Even in my own personal family, like my dad has gone through quite a bit of stuff within the vascular world. He has had peripheral vascular disease. But anyway, he has multiple surgeries, multiple bypass surgeries. Recently, he had a amputation of his left leg. Some of the nurses at the hospital he was at, funny story anyway. So they gave him the wrong, I've told them this is what he takes. This is what he takes for pain meds. This works for him. They thought it upon themselves, okay, we're going to give him this type of narcotic. He phoned me, I think it was about 4:30 in the morning. Dallas, I'm in such pain. They gave me this and this. And I just went, really? So again, I down to the hospital and I talked to them in a very, I talked to them quite sternly. I said, what are you guys doing? How come you did this? So being a patient advocate that way for my dad, and I do that for all my patients, make sure if something is occurring that shouldn't be, and being an advocate for the families, because sometimes it's the first time in the healthcare system and they just need a little bit of help going through what they're going through, and just being there for them. finding what, and I always ask them, especially when they're in a great amount of pain, say Dilaudid doesn't work for them, and ask them, what have you taken in the past in hospital that's worked for you? And you're really that go-between between the you and the doctor. And sometimes, okay, the patient isn't working well on this med. You suggest something to the doctor. They may agree or disagree with you, but at least you've made the suggestion, and you report back to the patient, and being clear a lot of the time with what the message is, because sometimes you'll find with patients the doctor will come in for 5 minutes, ramble on about something, some condition, some drug that they've been given, and the patient has no darn idea what they're talking about, and they're going, what? So you go, and they'll ask you, what was this they talked about? So you reiterate it in a way that they can relate to or understand, so that they get the message they need, so they can make decisions on their own healthcare.
Mm-hmm. Well, that makes a lot of sense. You sharing that story about your father, about pain medication in particular, because you have mentioned pain in some of your advocacy stories earlier in this interview as well, and your strategies around understanding how their pain is treated, how they manage it. So that's a really strong connection and thread that has resonated with you, and you've made that a priority in your nursing. Yeah.
Yeah.
Yeah, there usually is a strong story. Obviously, I was bullied in the past, and that's my strong story when I help people overcome conflict. That's my passion, is to help people move past those potential situations that are harmful for them. And you're doing the same, but in a very different fashion. You're focusing on that pain management and patient-centered. And
well, and one thing I said to these nurses, I said, do you guys practice family-centered or patient-centered care here? That's the biggest thing we're at the hospital I work at, is patient-centered care. Are you asking, and I always say this to patients and their family, I said, I'm not just taking care of the person in the bed over there, I'm taking care of you too. Let me know if you have any concerns that I can bring up to the physician, or I can relay to you and make you more comfortable here while your loved one is here. Oh, thank you, nurse. Thank you for doing that for me, because they've never experienced that before, potentially. And people forget that they're not only taking care of the patient in the bed, they're also taking care of the family that's attached to that patient. I call it the patient constellation, because really, you're not only taking care of the patient, you're taking care of their family as well. Especially when you're dealing with folks with Alzheimer's and dementia, you're dealing with a lot of families that are really concerned about their parents.
Yeah, well, and it sounds like you are that family concerned about your family, right? Like you were on the other side of that, hearing your dad go through his multiple journeys. And as you were sharing that story, I did recall back to some of the stuff you had shared. We've known each other for a long time, that he's been in and out for a while. And has really been, are you his only family?
Yeah.
Yeah, I had thought that as well. So you really have to, step up, or.
Yes.
Yeah.
And again, I've had families come to me with that before. I'm his only family. I'm her only family. Or now with COVID now breaking out, where there's a new visitor policy throughout every facility in Edmonton, if I'm not mistaken, that folks cannot visit their family members unless they're what they call total comfort care, or C1, or unless special arrangements have been made that somebody can be there with them. I had a family call me and say, you're their family now, you have to advocate for them and help me out. And I had somebody break down on tears on the phone. I said, I'm sorry this is going on. I'll do the best I can to make her comfortable and make sure that she has what she needs. And again, it's just some people rush through, and I find now, coming back to medicine again for a second time, I've found taking a little bit more time with care, making sure that you're not rushing through what you're doing, and having that conversation with the patient, they're a little bit more at ease than when you're rushing through everything and just trying to get the job done and you don't care. Some people, that's what they do. Rush in, and they're very rough with the patients in pain. And then you got to remind that person, if you're working with them, slow down a little bit. Imagine yourself in this position. How would you feel? You're exposed. You probably feel quite violated. Let's slow down and not do this to the person.
Yeah, I do think there's a lot of system issues that maybe lead healthcare providers to be so quick with their work that They wouldn't
Mhm.
normally choose that if they had all the time that they
Well,
would like
exactly.
to.
Exactly.
Yeah. I mean, you
I
do see it, and you're right. There are some people who it has become a job for them. They've become a little bit rough around the edges, but I think for the most part, people are just trying to survive. And
Yeah. And
yeah,
especially with this new challenge that we faced with COVID-19, little bit of nerves are getting frayed, a slight
yeah,
bit. But I mean, it's about being there for each other, trying to support what's going on and trying to support who's around you and trying to, of course, and what we're there for is to support the patients so they're not, number
yeah.
one, scared in the hospital, which happens especially with people with dementia,
Hmm.
and making sure they're not lashing out, making sure they're comfortable and they're not um, causing you harm or themselves harm, most importantly.
Can be a challenging task for sure. It sounds like that advocacy is probably your secret sauce that you bring to your nursing profession.
For sure.
Yeah. Now, we were talking offline before we started. You had also mentioned the military background and how that
Mhm.
has helped you to be able to read situations and adapt your communication. Do you want to
Yes,
speak to that a little bit?
for sure. One thing that came to the forefront when I did a lot of my military training was something called situational awareness. So, reading the situation and responding accordingly to previous skill sets that you had in the past and how you responded to them. I do that all the time. You have to read the situation. Some people are inept in that. Some people don't have a clue. I mean, I work with nurses. I remember one lady running around confused, and I said, "Let me help you a little bit. Do you need help?" And she goes, "Yes." Okay, let's help you a little bit more, and let's guide you that way. So having situational awareness and a background in whatever you're doing, and one of the biggest things I found is being okay with saying you don't know something so you don't harm somebody. That's the biggest thing.
Hmm.
It's okay to say you don't know so you can educate yourself, and having that situational awareness. That's the biggest one. What are your knowledge deficits and how can you correct them?
Yeah,
And knowing where the
absolutely.
resources lie. And biggest thing, knowing your scope of practice and not going outside your scope of practice.
Yeah, I would totally agree. That's why I teach my students as well. When we go to clinical, that's the one thing I say. Patient safety is the priority. If you don't know what you're doing, you got to say something, because that's where patient harm happens, is when you just try to work your way through something, right?
Hmm.
Mistakes happen. Good intentions lead to bad outcomes. So let's make sure we get those good intentions matched up with good outcomes.
Exactly.
Yeah. Well, that's been a really fascinating conversation. Is there anything you would like to share with those who are listening? Like, what would your takeaway be for them as they either enter the nursing profession or looking to transition?
Transitioning from one area to another. Research, watch YouTube videos on what you're doing, what you want to go into. Talk to people around you and see what their perspective is on where they've been and see where you want to go. Like I said, for me, I thought I was going to be an OR and ER nurse. Didn't work. I found myself back in medicine, which is fine for me for now. It's a ongoing thing, and there's always evolving knowledge with that. Oh, another thing, like I said before, don't be afraid to question your own knowledge on a daily basis. Have 3 questions for yourself when you come home. Do I know this? How do I solve it? And challenge yourself all the time. Learn new techniques. Talk to the physicians you work with. See if you can watch what they're doing, especially with things like chest tube insertion, which sometimes I get to watch. It's quite fascinating.
Mm-hmm.
Ask the nurse educators, is there anything they can show you or any perspectives on your own learning that you could do? And big thing, if you're in a float position like I am, get all the certifications you can, because you never know where you're going to use them.
Mm-hmm. What kind of certifications come off the top of your head there? What are you thinking?
Um, for myself, I have ITLS from the military, which is International Trauma and Life Saving. I have ECG administration, lab draws, phlebotomy that I can do. Central line access and drug administration, IV certifications. Haven't been PD trained yet, and I haven't been vent trained yet. So again, having some
PD.
certification, peritoneal
Oh,
dialysis.
thank you.
Haven't done that.
Yeah. But there's opportunity to learn those things, it sounds like.
Oh yes.
Yeah.
So like, and within the medicine program where I'm at, they have a intermediate care unit that you can get trained for, which isn't common, or they don't often offer that training. So again, when it comes up, being the first one to put up your hand and say yes.
Mm-hmm. Were there any
and being open to those opportunities.
Yeah, were there any opportunities that came up as a result of COVID, where they were starting to reshuffle people? Was there any unique things that came up?
Yes. Let me think. They were redeploying people. Like I was seeing a lot of allied health following healthcare aides around. This is how we do this. This is how the MediLift works. I'm going, what the heck are you guys doing here? What's going on? So just redeployment of people. I don't know if they've reopened up any COVID specific units yet. They haven't. But yeah, having folks that were previously retired, there's been offers given to them. There's screening opportunities now that have opened up. I don't think of anything else off the top of my head.
Okay. I've heard of, I tried to get in on the ICU training when Jason Kenney first announced he was going to do a little bit of advanced, accelerated training was the word for ICU. That's my background, but I've been out for so many years. I'm like, yes, I want in that refresher and put me back in the ICU. And I heard they did run a course, but I was too late to get in on it. So darn it anyways. You had also mentioned, I want to make sure we share this, about how hard it can be to get a job.
Yeah. So, again, even being internal with one of the healthcare agencies, I wasn't guaranteed a job. It's just applying to everything that you can, even if it's home care to start off with and then finding something else and just keep applying. I know how depressing it can be looking for a job. You just can't give up on yourself and just keep applying. And again, tailoring your resume to fit the job posting is a big one. That's where I went, okay, what am I doing wrong? And just educating yourself on, maybe I should submit it to a professional resume writing service and see what their perspective is. Here's my resume. Maybe it's too long. And you get it back from them and have them proofread it and decide, okay, this looks like a better resume for me. So again, and give your resume even to if you can't, or if you don't have the opportunity to submit it to a professional resume writing service, or have somebody else proofread it, because I mean, more eyes are better than one in that case.
Awesome advice. Awesome advice. Thank you so much for joining us on Frontline Nursing Podcast today. For those who are listening and would like to see the audio visual of this interview, go on over to the frontlinenursingpodcast.com. You can join up there for the membership site. You'll get full early access to the video, as well as you get the after the recording and a download that we're going to co-create just for you. Thanks for listening. Now, the fun hasn't stopped just because this interview is over. Join us at the membership site, frontlinenursingpodcast.com, where you will get the video footage of this interview and our after the recording. In addition, our guests create a download specifically designed for you. Now, if you'd like to be featured here, email me at info@tammydunnett.com and we'll get your story online.